Alright, for those of you that have been having a little bit of trouble trying to really grasp and study and practice for RS-221 quizzes, I have broken up a little bit for you. I took some of the Tib-Fib video and I did a little breakdown just of maybe the first minute or so, and I created 5 quick questions that maybe would come from just that portion of the video alone. I did a little breakdown. The answers are always there in the iTunes video, and they're just needing to be broke down inside your head for taking the quizzes. So I'll do a little breakdown for you, then we'll address each question, go back to the video. So hopefully this helps you guys out. So here we go. For the AP projection of the Tib-Fib or lower leg, place the patient in the supine position. Adjust the leg so that the femoral condyles are parallel with the IR and the foot is vertical. Be sure to dorsiflex the ankle. The central ray should be perpendicular to the center of the leg, and collimation should be extended 1.5 to 2 inches beyond the ankle and knee joints. Furthermore, collimation should have 1 inch on each side of the leg. Unless the leg is unusually long, the IR needs to extend beyond the knee and ankle joints to prevent them being projected off the IR by the diverging rays. The IR must extend 1.5 to 2 inches beyond the joints. When the leg is too long for these allowances and the site of the lesion is unknown, 2 images should always be made. If the lesion is unknown, the leg is imaged with the ankle joint and a separate knee projection is performed. Okay, so let's look at question 1. What is the central ray angle for an AP projection of the leg? 0, 5, 7, or 5 to 7 degrees? Let's listen to what I had to say. The central ray should be perpendicular to the center of the leg. Okay, so there you have it. Perpendicular is the same as 0 degrees. So the answer A, 0 degrees, should be the correct answer. Let's look at number 2. What is the position of the femoral condyles when the leg is properly positioned for an AP projection? Perpendicular to the IR, parallel to the IR, at a 15 to 20 degree oblique? Let's see what I had to say. Adjust the leg so that the femoral condyles are parallel with the IR and the... There you have it, the answer B, parallel to the IR. Let's go ahead and look at number 3. How far should the IR extend beyond the ankle or knee joint for an AP projection of the leg? ½ inch? 1 inch? 1.5 inches? 4 inches? Let's see what I had to say. The IR must extend 1.5 to 2 inches beyond the joints. There you have it, the most correct answer, 1.5 inches. Now let's move on to the next question, question 4. Often, the leg is too long to fit on one IR. Which joint or joints should be included on the IR when the site of a lesion is unknown? The ankle joint, the knee joint, both joints on 2 IRs, or the joint closest to the lesion? Let's see what I had to say. When the leg is too long for these allowances and the site of the lesion is unknown, 2 images should always be made. If the lesion is unknown, the leg is imaged with the ankle joint and a... So there you have it. When the site of a lesion is unknown, the ankle joint should be included on the IR. Now let's break down a little more difficult question, number 5. It's kind of a critical thinking question. Often, the leg is too long to fit on one IR for radiographs. Which joint or joint should be included on the IR when the site of a lesion is known? Now we just covered the question of when the site is unknown, and I specifically stated that the ankle needed to be included with the rest of the foreleg. However, here we have to do some critical thinking. The first thing we can do is we know that it's no longer the ankle joint because that is when the site is unknown. From a radiation protection standpoint, getting the answer C, both joints on 2 IRs, doesn't make much sense either. Why would we want to radiate the patient more than we already had to? So we can cross off C. Then you have B, the knee joint. What would be the purpose for just doing the knee joint? What if the lesion was closest to the ankle? Would getting a knee joint image be beneficial to that diagnosis? I don't think so. So to critically think, the answer D, the joint closest to the lesion, would be the most important or relevant. And finally, let's do just one last question. Which of the following should clearly be demonstrated on a lateral projection of the leg? The knee joint? The ankle joint? The entire femoral condyles? Maybe some of both. Let's see what I had to say. When evaluating your lateral projection, you should be able to visualize both the ankle and the knee joints. Well, there you have it. The ankle and the knee joint. The answer A, both 1 and 2, is the most correct answer. Hopefully, going over these iTunes videos, doing a small breakdown for you, and tying them in with these questions can help you guys study and learn this information better in the future. If you liked this cast today, please go ahead and add this onto the discussion board and let me know how helpful it was to you. Have a good weekend, guys.